I will start with the background, the bony pelvis, and then move on to the pelvic organs and so on. The pelvis is formed of two hip bones on either side, and the sacrum and the coccyx in the center. And there are, so don't get mixed up between the pelvis and the hip bones. If you are given a hip bone, one of these, during a viva exam, wherever, call it hip bone or os innominatum rather than pelvis. Okay, this is pelvis. So pelvis is a structure formed by two hip bones, sacrum and coccyx. Remember this point. Then pelvis is conventionally considered a basin with holes in its walls. That's how it is described. And its bones, the bones that we just described, are bound together by dense ligaments. Now, there are two types of joints in the pelvis connecting up these bones together. One is a symphysis pubis, symphysial joint, which is called symphysis pubis, and it is a secondary cartilaginous joint. And the other two joints are the sacroiliac joints, which are synovial joints. If you just take a look at the symphysis pubis, the secondary cartilaginous joint, like any other secondary cartilaginous joint, it has a fibrocartilage plate in the center, this one, and two hyaline cartilage plates on either side of the fibrocartilage plate. This is the common arrangement for any symphysis joint. Then when it comes to movements, slight angulation, rotation, separation and compression are possible, mainly during childbirth, pregnancy and childbirth. The other two joints are the sacroiliac joints, which are synovial joints, and even though they are synovial joints, there is varying degree of fibrous adhesions in this joint, and in old age more adhesions, and sometimes in old age there is ossification. There is irregular articular surfaces covered with hyaline cartilage. If you look at the articular surface, there are two regions in the articular surface. There's one region for the ligaments to get attached, which are called interosseous sacroiliac ligaments. And there is another area in the shape of a boomerang here. You can see it. In the anatomical position, this is how you see it. That is covered by hyaline cartilage. There are several ligaments stabilizing the sacroiliac joints. You get this anterior sacroiliac ligaments, and you get posterior sacroiliac ligaments. Then you get interosseous sacroiliac ligaments. There are three types of sacroiliac ligaments. These ligaments contribute to the stabilization of the sacroiliac joints. Then other than that, the other ligaments in the area, which are the sacrotuberous ligament and the sacrospinous ligaments, which is faintly seen here, which is attached to the ischial spine. Sacrotuberous and sacrospinous ligaments, which I have mentioned here, are also important for the stabilization of the sacroiliac joint. Then, when you did the posterior abdominal wall, you learned about the iliolumbar ligament. This one, iliolumbar ligament, which is attached between the L5 transverse process and the iliac crest, to which the quadratus lumborum muscle is attached in the posterior abdominal wall. That is also important to stabilize the sacroiliac joints. And the direction of the sacroiliac ligaments, anterior, posterior, and interosseous sacroiliac ligaments, is such that the body weight is easily supported by the pelvis. The direction is in this direction. Therefore, the forces can be managed easily by the sacroiliac ligaments. Forces can be transmitted from through the spine into the lower limbs, to the two sides by this arrangement. And the movements, even though these are synovial joints, again there is minimal movement other than in pregnancy, allowing slight rotational changes, rotation, separation, and increase in pelvic diameters by these movements. And pelvic fractures, a direct blow to the pelvis itself or the lower limb, like in a falling from a height on the feet, or if you hit the dashboard of the car during a road traffic accident, if you hit the knee joints here against the dashboard, you can get, especially if the limbs are abducted, you can get the head of the femur fracturing the acetabulum and driven into the pelvic cavity. So in pelvic fractures, since the pelvis is a very firm ring, if you break it, if you try to break it in one place, you cannot break it in one place. It usually breaks. If you try to break it in one place, it breaks in another place. You can see here the break or dislocation. You can see there's dislocation of the symphysis pubis here, and at the same time there is dislocation or separation of the sacroiliac joint on the left side. So if you try to fracture also in one place, if you try to fracture the ring in one place, there would be a fracture in another place somewhere. So because it's a very firm ring, remember this point. Then the other point is, now you can see here, now there's fracture of the acetabulum, and the head of the femur in this case is driven into the pelvic cavity, fracturing the lateral wall of the pelvic cavity. Now, in an injury like that, there can be damage. Now, later, when you study the pelvic cavity, you will see that the ovaries, the obturator arteries, nerves, and ovaries are very closely related to the acetabulum inside the pelvic cavity. So when the acetabulum is fractured, the lateral wall of the pelvis is fractured, and the head of the femur is driven into the pelvic cavity, you can damage these structures like ovary and vessels related to it, obturator vessels and nerves in that area. And more than that, it can damage the internal organs here, the bladder, uterus, rectum, of course, is at the back. But any of these pelvic organs can get damaged depending on the degree of the severity of the fracture. So then it will become a serious problem. One issue is the damage to the organs itself. Second issue is heavy bleeding, because the pelvic cavity can accommodate several liters of blood without the notice of the doctors, because you don't see it outside. You will notice it by the pallor, the paleness of the patient, drop in the blood pressure, and those things will only show you that there is blood loss unless you do a ultrasound scan and detect it. Therefore, remember, it is called concealed blood loss. Concealed means it's hidden. Hidden blood loss is an issue with pelvic fractures. Even with the fracture of the femur, you can have it to some extent, but pelvic fractures are notorious for that. So remember that issue. You will see, you will learn this when you do the clinical years. Then about the pelvic inlet and pelvic outlet. So pelvic inlet is also called pelvic brim. Okay, pelvic brim, and these are the ones that contribute to form the pelvic brim. It is symphysis pubis in front, symphysis pubis. Then the pubic crest is there, just lateral to the symphysis pubis. Then you get the pectineal line. You can call it pecten pubis also. Then you get the arcuate line. That area is arcuate line. Then you get the margin of the ala of the sacrum. Then you get the front of the promontory. Then you get the same things on the other side. So that will form the pelvic inlet or the pelvic brim. And I don't know whether this disturbs your view. I can bring it down. Can you see this? I don't know. My view, it's so. Anyway, now when you talk about the pelvic brim, the pectineal line, and the arcuate lines. So the pectineal line is this one. Sorry. Pectineal line is this area and the arcuate line is that area. Taken together, pectineal line and arcuate line, some people call it iliopectineal line. So remember this point. Some authors call it iliopectineal line. If someone calls it iliopectineal line, that is this whole area up to the pubic crest. Okay, so that whole area. Okay, the pelvic outlet. Pelvic outlet is diamond shaped. Now the pelvic inlet, there are different shapes. We will discuss these shapes. You can have oval shaped things like that. You can have, you say, like kidney shaped or heart shaped. Okay, different pelvic inlets. Based on that, you name them. We'll come back to it. Pelvic outlet is usually it's diamond shaped. Pelvic outlet, and it is bounded in front, just like in the inlet, bounded in front by the symphysis pubis, then the ischiopubic rami, then the ischial tuberosities in that area, then the sacrotuberous ligaments, and the coccyx here. So these are the boundaries, and later when you learn the perineum, you will see that the boundaries of the perineum are also the same. Okay, remember that point. So this is a roughly a diamond shape you get in the pelvic outlet. Then the pelvic cavity has two components. There is a false pelvic cavity and a true pelvic cavity. Now, if you consider the false pelvic cavity is the area, is the pelvic cavity that lies above the pelvic brim. That is that area. Above the pelvic brim, you get false pelvic cavity. Then, between the pelvic brim or the pelvic inlet and the pelvic outlet, here you get the true pelvic cavity. So, false pelvic cavity here and true pelvic cavity here. Remember that point. And it is also important to remember that the false pelvic cavity, why is it called false pelvic cavity? Because it's actually the lower part of the abdomen. Okay, so the false pelvic cavity contributes to form the lower part of the abdomen, and this false pelvic cavity is bounded therefore in front by the lower part of the anterior abdominal wall, then on either sides by the iliac fossae with iliacus muscles and fasciae, and at the back with the lumbar vertebrae here. So these are the boundaries of the false pelvic cavity, which contributes to form the lower part of the abdominal cavity. Then the true pelvic cavity, as I said before, it lies between the pelvic inlet and the pelvic outlet. And if someone uses the term pelvic cavity rather than specifying whether it's true or false pelvic cavity, always you take it as true pelvic cavity. So if someone says pelvic cavity, he refers to the true pelvic cavity, not the false pelvic cavity. So remember that point, because most of the time this term is used. Okay, when we use to write things in anatomy, we use pelvic cavity rather than true pelvic cavity. Remember that point. Then the other point is the true pelvic cavity. As you can see here, it is shallow in front and very deep behind. So if you go by centimeters, about 4 centimeters depth in front and about 12 centimeters, almost 3 times depth at the back. Then in the anatomical position, you already know that the pelvis is tilted to the horizontal plane. So if you, before that, the anatomical position, the pelvis is tilted, of course, and the tilting is such that in the anatomical position, the anterior superior iliac spine and the superior border of the symphysis pubis both lie in the same vertical plane. They lie in the same vertical plane. And the other point is, if you take the horizontal plane, to take the horizontal plane, the plane of the pelvic inlet. Now, this is the plane of the pelvic inlet or the pelvic brim. The plane of the pelvic inlet in the anatomical position is about 55 degrees to the horizontal plane. And if this angle becomes more than 55 degrees, the tilt of the pelvis becomes more than 55 degrees to the horizontal plane, then there can have problems during delivery of the baby, because during the delivery of the baby, head has to, I'll try to draw it, the fetal head, the head of the baby has to enter the pelvic inlet to start the delivery. It's a first step in the delivery of a baby. The head enters the pelvic, the inlet, which is called head engagement. Head engagement, and this head engagement becomes difficult when the tilt of the pelvis is more than 55 degrees. Remember that point. So this is what I just said. When the angle is more than 55, the entry of the fetal head or the head engagement becomes difficult. Now, if you take a normal person and you try to draw the pelvic cavity with this line, you can see the cavity, the pelvic cavity is projected towards the buttocks of that person, and the plane of the inlet or the pelvic brim, this plane, bounds the pelvic cavity in front, rather anterosuperiorly. And if you try to draw a sagittal section over this one, you can see that this is the plane of the pelvic inlet or the pelvic brim, and you can see the vagina, urethra and the rectum are parallel to the plane of the inlet. So this is vagina, here this is the urethra, and this is the rectum. They are more or less parallel to the plane of the pelvic inlet. The anteverted uterus, we will get back to what is anteverted. The anteverted uterus is the normal position of the uterus, and the anal canal. You can see the anal canal here. The anteverted uterus and the anal canal, they are actually the uterus here and the anal canal are actually at right angles to the plane of the pelvic inlet. You can see that. Okay. In other words, between the rectum here and the anal canal, there is almost 90-degree angle. You can see it comes up and it comes down and goes like that. So we will talk about these things later again. Okay. So sometimes the uterus might not be in this position. This is anteverted position. It can be like this, or it can be even like that. Okay. So there are names for these different positions. So these are called retroverted, anteverted, and this is retroverted if you turn it the other way. Okay, we'll come back to it later. Then at the beginning I said there are different shapes of the pelvis. Now there are different shapes. Of course, you can see 1, 2, 3, 4 shapes at least here. But I'm not going to talk about all these shapes. What you need to know is that most of the male pelvises have an android shape. And this shape is mainly based on the inlet. Yeah. And the usual female pelvis is gynecoid. But these biological systems, they don't have one straightforward way of having things. So there's a varying degree of android and gynecoid shapes in individual males and females. So a female having a shape, a pelvic shape more like android, will have problems when it comes to delivery of the baby. Males having gynecoid will not have a problem. Okay. Then female, if you compare the male and female pelvis, I will not compare all the points. There are several points if you consider the difference between male and female pelvis. some of which are important forensically, but in forensic medicine. But here, the most important thing I need to stress is that the shape of the inlet. Now, usually the females pelvic inlet is oval shaped, and in males it's rather heart shaped or kidney shaped. So this is gynecoid and android shapes, and the pelvic outlet is also not so important here, but the pelvic cavity is important to remember. Now, in a female, pelvic cavity is more or less cylindrical, and in a male, it is more or less funnel shaped, because inlet is, you can see it here, so inlet is smaller compared to the female pelvis inlet, because of the inward direction of ischial spines and all. In the male pelvis, ischial spines are directed inward like that. Okay. Then the pubic arch or the subpubic angle in females, I don't know whether you can see it here. Yeah, in females, the subpubic angle or pubic arch is about it's more than 80 degrees, and in males it's less than 80 degrees. We show it with fingers usually. In females, the angle is taken like this with the thumb and the index finger, which is more than 85 degrees, and in males it is shown with the index and middle fingers like this. Then measurements of the obstetric pelvis, the measurements of an ideal obstetric pelvis. So always remember that even though we say ideal obstetric pelvis, no one will have this ideal obstetric pelvis. Most of the females will have different degrees of variation from this. But in an ideal pelvis, as you can see here, at the inlet, now this is inlet, and this is outlet, inlet and outlet. At the inlet, the transverse diameter, you don't need to by heart these values, but if you compare the two, you can see at the inlet, the transverse diameter is more than the anteroposterior diameter. That's the take-home message. And at the outlet, the anteroposterior diameter is more than the transverse diameter. So at the inlet, the transverse diameter is more. At the outlet, anteroposterior diameter is more than the transverse diameter. So that is the point I wanted to raise here. So that's an important point to remember, which we can check in MCQs even, and not the exact value. It is that the transverse diameter is more than the anteroposterior diameter in the inlet, and the anteroposterior diameter is more than transverse diameter in the outlet. Now, when it comes to the fetal head, fetal head has two types of diameters. An anteroposterior, there are several anteroposterior diameters based on how the head enters the pelvic inlet. If this area, the forehead, enters the pelvic inlet first, then the diameter that is relevant would be this one, which is given different names. It is called vertico-mental. Mental is the chin area. This is the vertex area. So it's called vertico-mental, and you can see that it is very high. It's about 13.5 centimeters, which will not pass through the inlet if you have a 13 centimeter inlet. So then if the face presents, if the face enters the pelvic inlet first, then you get this submento bregmento. You don't have to remember these terms, okay? Whatever you call this, you can see that if the face enters the pelvic inlet first, so this is the diameter that is important, anteroposterior diameter, which is only 9.5 centimeters, then it is possible to pass through this inlet. So based on the flexion of the neck here, flexion of the neck and which part that first enters the pelvic inlet, the anteroposterior diameter of the fetal head that is engaged into the pelvic inlet is decided, and it can vary. At least in this example, it can vary from 9.5 to 13.5. So that is one point that you need to remember. Then the other point is that there's a transverse diameter to the head also. Now from, say, from one side to the other side, that transverse diameter is fairly constant, and it is less than the anteroposterior diameter. Therefore, no one talks about the transverse diameters. It's always the anteroposterior diameters that will create problems. And the other point is, we have already discussed here and decided, and that the transverse diameter is more at the inlet, and the anteroposterior diameter is more at the outlet here. Therefore, whichever the way the head enters, whether it's face presentation or forehead presentation, or even the vertex presentation, whichever that comes into the pelvic cavity first, it's best if it meets the transverse diameter of the inlet first and the anteroposterior diameter of the outlet, because these are the high diameters. So what happens is that the head rotates between the inlet and the outlet to meet the highest diameter of the inlet and the outlet. So at the inlet, head is usually in that position, transverse position, and at the outlet, it has to turn 90 degrees to come up to that position. So face can be in the mouth can be on this side, then the forehead can be on the other side. It can change. Whatever it is, it has to rotate 90 degrees from inlet to the outlet. So that is also another point. So if you have to pull the baby, say during delivery, if there's obstruction, some degree of obstruction, and you will learn these things later. Okay, you have to pull the head of the baby. Always when you pull, remember that behind the head, you get the head, and then you get the neck, and you get the shoulders also. So behind the head comes the shoulders. So shoulders also will have to pass through this process. It will have to meet the transverse diameter of the inlet and the anteroposterior diameter of the outlet. So it's not only the head, you have to have the shoulders also coming through this, and you will have to rotate the baby when you pull the baby. In case you have to pull the baby, you can't just pull straight, because rotation is taking place to meet these diameters. Remember this point. You will learn it later also. Then the pelvic walls, even though it is not, the pelvic cavity is not a box like this, but still the walls are defined like as if it's a box. So you have a posterior wall, lateral walls, and an anterior wall. But this, remember this lateral and posterior walls, they actually make posterolateral walls, even though the description is posterior and lateral. Okay, remember this point, otherwise you get confused. So the lateral walls, that is this area of the pelvis, the pelvic cavity, is formed by the hip bones. You know what is hip bone now. Hip bones and the obturator internus muscle with its obturator internus fascia. So that is the lateral wall. Then the posterior wall is formed by the sacrum, the coccyx here, and the piriformis muscle and fascia covering the piriformis muscle. So that's what I said. It's posterior or posterolateral rather than just posterior. But the textbooks typically describe it as the posterior wall. Then anteriorly, you get the symphysis pubis and the bodies of the pubic bones on either side, and the rami of the pubic bone, superior and inferior rami of the pubic bones forming the anterior wall. Then the floor of the pelvic cavity is formed by what is called pelvic diaphragm or the pelvic floor, which is attached across the internal oblique muscle like this. I'll describe that later. Someone is asking a question. We'll see chat. Sir, what to do? Baby does not. What to do if the baby does not rotate? No, you will learn this. If the baby does not rotate, then you will not see the head coming through the vagina. So you can't do anything at that point. You can do something if the head has come out at least partly through the vagina, and the rest of it is stuck. You might be able to pull it either with your hands or with applying forceps or vacuums. There are vacuums that you can apply. But if it gets stuck here, without rotating, if it gets stuck high up, so you don't see any head coming through the vagina. So then, you know, there are different protocols that you use in the labor room. You will go for emergency cesarean section or something like that, and you take the baby not through the pelvic cavity but through the anterior abdominal wall. You cut the wall transversely and take the baby out. Okay. So it's not only rotation, there can be many other reasons that can lead for cesarean sections, emergency cesarean sections. Okay. So this is the pelvic flow over the pelvic diaphragm, which we will discuss later. So, okay, so this is a better diagram from Grant's Atlas. Now you can see this is a sagittal section. You can see the sacrum and the coccyx here. You see the symphysis pubis here. So this is the pelvic brim or the pelvic inlet, and this is the obturator internus muscle here. Obturator internus muscle, and this is these muscles. They form the pelvic floor. We will come back to it. And the middle part of the pelvic floor has been removed here to show the lateral wall of the pelvic cavity. So the pelvic other muscle will get attached like this across the obturator internus muscle. You will need some time to understand this clearly. Okay, we'll take it up anyway, you know, several times. So then, now that I discussed it, I'll tell you now. If the pelvic diaphragm is like that, so the pelvic organs lie in that area in the true pelvic cavity, and here below the pelvic diaphragm, therefore, actually what you get is the perineum. Okay, so perineum is that area. Okay, we will discuss that in detail later. Okay. So the pelvic diaphragm consists of several muscles: pubococcygeus, iliococcygeus, and ischio-coccygeus muscles. Now, if the muscles are like this, then there is a fascia over the muscles above and below, which is called superior fascia and inferior fascia of the pelvic floor, pelvic diaphragm. Okay. Now, we will go into the details of the pelvic diaphragm. Now, if you take the hip bone, this is hip bone, or os innominatum, you remember that there is a foramen here called obturator foramen. Okay, obturator foramen in the hip bone, and in the living, that foramen is covered with the membrane, which is called obturator membrane. Okay, leaving a very small gap above, which is called obturator canal, through which the obturator vessels and obturator nerve passes into the thigh, medial compartment of the thigh. You have studied that. Okay, so this part you already know. Now, over this obturator membrane, obturator internus muscle is attached. So we said that the lateral wall of the pelvic cavity is formed by the hip bone and the obturator internus muscle. So this is how the obturator internus muscle comes into form the lateral wall, getting attached over the obturator membrane. Then there is fascia, pelvic fascia. We'll discuss pelvic fascia later. Pelvic fascia covering the obturator internus muscle, which is called obturator fascia or obturator internus fascia. Okay, so this covers the obturator internus muscle, and there is a thickening over this fascia, which is called tendinous arch. This area is called tendinous arch, or you call it white line. And this is the area across which the pelvic diaphragm is attached. And below this, you get the perineum. Above that, you get the pelvic cavity containing pelvic organs. Then, the three muscles that we mentioned that contribute to form the pelvic floor, pelvic diaphragm, are here. You can see pubococcygeus muscle in front, iliococcygeus muscle in the middle, and ischio-coccygeus muscle at the back. Now, these pubococcygeus and iliococcygeus muscles, I don't know whether this disturbs you. Anyway, I'll raise it. So, pubococcygeus and iliococcygeus muscles taken together, they are called levator ani. So if you read levator ani in a textbook, or if someone talks about levator ani, that refers to the first two muscles, pubococcygeus muscle and iliococcygeus muscle. And the third muscle, the ischio-coccygeus muscle, it is also called coccygeus. You just call it coccygeus. So remember these terms. There are different terms. So the basic terms are pubococcygeus, uh, iliococcygeus, and ischio-coccygeus. But someone can talk about levator ani or coccygeus. Now you know the basis of using these terms. Then few more things about the pelvic diaphragm. Uh, okay, I'll draw the pelvic diaphragm on one side. Okay, now you see the three muscles here: pubococcygeus, iliococcygeus, and ischio-coccygeus muscles on the left side. And these are the muscles on the right side: pubococcygeus, iliococcygeus, and ischio-coccygeus. You can see the posterior end of the pelvic diaphragm, which is mainly formed by the ischio-coccygeus muscle and even the other muscles. They ultimately get attached to the coccyx here. That's why you call it pubococcygeus, iliococcygeus, ischio-coccygeus. Okay, so the posterior end is the coccygeus. Then in front of the coccygeus, you can see this area. There is the tendinous. There is a tendon in front of the coccygeus to which the muscles from the two sides get attached. They take origin, they take mutually, they take origin from each other at this tendinous area, which is called anococcygeal raphe. Now you will see raphe in other areas. You will see raphe when you study the head and neck region, the pharynx. In the pharynx, you get one raphe. There are 2-3 areas where you get raphe, where a muscle gets origin from a tendon area like this without having bones there. So this is called anococcygeal raphe because coccyx is at the back and you get the anorectal junction here in front. That's why you call it anococcygeal raphe. Okay, now the innermost fibers of the pubococcygeus muscle, this muscle, the innermost fibers of the pubococcygeus muscle are called puborectalis. Puborectalis. And this inner layer of muscles of pubococcygeus, which is called puborectalis, it forms a sling around the anorectal junction. Now, if I draw if you remember the planes in the previous one, you saw the rectum like this, parallel to the pelvic inlet. Then you saw the anus like this, anal canal, at almost at right angles to the pelvic inlet. Now, this puborectalis muscle, it is like this. It forms a sling around the anorectal junction. Your anococcygeal raphe lies behind here. Coccyx is here. Your pubis is here. Okay, so that's how it is. So then this is the puborectalis. This is the anorectal junction is here. Then this area in front of the anorectal junction, the gap here is called urogenital hiatus. This gap is called, I can see your messages are come back to it. So this is called urogenital hiatus. So in females, you get vagina and urethra passing through the urogenital hiatus. And in males, you get the urethra passing through the urogenital hiatus. Then some fibers of the pubococcygeus muscle also pass around the vagina here, forming pubovaginalis. So you have puborectalis and pubovaginalis. Both are contributed to by pubococcygeus muscle, innermost fibers of the pubococcygeus muscle. Okay, so let me see your chat. Sir, what to the baby? Okay, sir is the anococcygeal raphe. also what is called the anococcygeal body. No, anococcygeal body is condensation of fascia below anococcygeal raphe. So if you have the anococcygeal raphe like this, anococcygeal body lies below that. Okay, so it's not the same. Okay, but you don't need to know too many things about it. But if you can read last there's a nice diagram and a description about the difference between the anococcygeal raphe and anococcygeal body. It's not the same. Okay. Okay, so I will delete some of these things. Okay, so we will move on. Now, okay, this is the diagram that I was trying to draw. You have the rectum here, you have the anal canal here, and you can see almost 90-degree angle. I'll delete these things, otherwise they will disturb the picture. So you get, this is puborectalis muscle, like this, that is that forms a sling around the anococcygeal, anorectal junction, and this is the anococcygeal raphe. Okay, so you have the muscles on either side. Your anococcygeal body is somewhere here, okay, which I didn't mention here. Okay, then you get the coccyx here. Okay, your coccyx is here. Then in a female, you get the vagina. This is vagina in front of the anal canal, anorectal junction and the anal canal, and you get the pubovaginalis muscle forming a sling around it. In males, you get prostate here sitting over the pelvic floor, which is in that area, and the muscle. Then the muscle there is not pubovaginalis; it is called levator prostati. It is levator prostati. Okay, in males. Then the pelvic diaphragm. In summary, the pelvic diaphragm, the fibers of the pelvic muscles, they have a origin in front and insertion at the back. So the direction of the muscle fibers is in a posterior inferior direction. Okay, so it's posterior inferior direction like this, like in this arrow here. But the gutter or the flow that is formed, this is the pelvic flow or the pelvic gutter that is formed, that has a direction, an antero-inferior direction. Antero-inferior direction. Muscle fibers are posterior-inferior. Direction of the flow, the gutter is antero-inferior, and this is important. This shape is important for the passage of the baby. Okay, passage of the baby. Peritoneal reflections. Now, the person who asked about the collection of blood in the pelvic cavity, whether it can be detected in the abdominal cavity, will be partly answered here. When you look at the peritoneal reflections. Hello, any questions? Yes? Yes, did someone talk? If you have questions, if you can't type, you can actually ask, no problem. Okay, now the peritoneal reflections, you have done the abdominal dissection, you have entered the peritoneal cavity, and you have seen the structures in the peritoneal cavity. Now you can see now this light ash colored or light blue area is the peritoneal cavity. Okay, so here you can see the pelvic organs like uterus, bladder in a female with uterine tubes and all that, covered above by the peritoneal, the peritoneum. They are covered above by the peritoneum, and therefore you call these pelvic organs like uterus, bladder, you call them subperitoneal. Okay, because they lie below the peritoneum. Now the peritoneum therefore has to lie above them, sometimes covering them in front and behind, and covering them superiorly in certain cases like bladder. You can see the peritoneal, the peritoneum gets reflected from the rectum. Now this is the rectum. It covers the rectum in front, gets reflected from the rectum onto the bladder. In this case, this must be a male. Anterior view of female. Okay, so this gets reflected onto the bladder. This is a male, onto the bladder, and then onto the anterior abdominal wall, covering the superior surface of the bladder. In a female, from the rectum, from the front of the rectum, you can see it gets reflected onto the upper part of the vagina, posterior fornix of the vagina, and the uterus. Covers the posterior wall, the fundus, and the anterior wall of the uterus, and then gets reflected onto the superior surface of the bladder. It does not cover the posterior surface or the anterior surface of the bladder. Covers the superior surface of the bladder, and from there it gets reflected onto the anterior abdominal wall. Okay, so there is this point is clinically important. We'll come back to it. Okay, first we come to the peritoneal reflections on the rectum itself. If you divide the rectum into upper 2/3, upper 1/3, middle 1/3, and lower 1/3, upper, middle, and lower 1/3, the upper 1/3 is covered in front and sides by the peritoneum, and the lower 1/3 is only covered in front by the peritoneum, and so the middle 1/3 is covered only in front by the peritoneum, and the lower 1/3 is not covered at all by the peritoneum. So it lies subperitoneally. Lower 1/3 of the rectum is subperitoneal. And you can also see that now if this is a female, you get the posterior fornix of the vagina here, then the cervix and the uterus here. So the peritoneal reflection from the rectum onto the posterior fornix of the uterus and the body of the uterus forms a pouch in this area, which is called rectouterine pouch. Rectouterine pouch, because the rectum is at the back and uterus is in front. Or you call it, this is a famous term, you call it pouch of Douglas, which is also clinically very important. We'll come back to it again later. Okay. So remember these points, which are also important. Okay, so we'll talk about the peritoneal reflections and come back to the pouches, pouch of Douglas and other pouches. So further about the peritoneal reflections, now we said it covers the posterior wall of the uterus, the fundus and the anterior wall, like this, covers like this, and contributes to form the outer layer of the uterus, the perimetrium. Then lateral to the uterus, on either side of the uterus, here and on the other side, either side of the uterus, the double folded peritoneum, you can see the two folds, double folded peritoneum actually is called the broad ligament. Okay, you call it broad ligament. Difficult to write, broad ligament here. Okay, and the broad ligament has two extensions. One extension is around the uterine tube. It is called mesosalpinx. And there's another extension to cover the ovary like this. These are extensions from the broad ligament. Okay, and that is called mesovarium. Okay, so the mesosalpinx and mesovarium are extensions from the broad ligament, which is none other than double folded peritoneum. So this is another nice diagram from Richard Snell Clinical Anatomy. So you can see the peritoneum covers the middle third of the rectum up to here, middle third of the rectum, gets reflected onto the posterior fornix of the vagina here, forming pouch of Douglas between the two structures, and covers the posterior surface, the superior surface or the fundus, and the anterior surface of the uterus, and then it gets reflected onto the superior surface of the bladder. Here you can see the anterior surface of the cervix is actually not directly covered by the peritoneum, and it gets reflected onto the anterior abdominal wall. Now the important point, the clinically important point here is this actually. When the bladder is filled, say not the usual filling, if you have an obstruction here, which is called the bladder outflow obstruction, if you obstruct the urethra, now in males, in the old age, their prostate gets enlarged, and when the prostate gets enlarged, since the prostate covers the urethra, the prostatic part of the urethra is covered all around by the prostate. When the prostate gets enlarged, there is obstruction to the urethra, which is called bladder outflow It's one form of bladder outflow obstruction. So if the bladder is obstructed at its outflow, it can get filled like this. So the filled bladder can above, now this is the symphysis pubis here. The filled bladder can appear in the lower part of the abdominal cavity. If you percuss, now somebody asked about percussing and detecting blood. Rather than detecting blood, you can easily percuss the anterior abdominal wall here. If you start percussing from that area and come down, you will detect this area of the bladder. So you will detect a dullness at that area of the bladder, and this whole area would be dull in the anterior abdominal wall, dull to percussion. And if you I'll draw it here, it's interesting. Okay. Now, if you draw the anterior abdominal wall like this, anterior abdominal wall like this, and if you have the pubic bone, symphysis pubis here, now if you percuss in that direction like this is percussing for the bladder. Okay. You will detect this dull light like that. Okay, so you will see you will detect the same dull line when there is pregnant uterus, gravid uterus, enlarged uterus. You percuss like that, you can draw this line because that is the first line where you get the dullness. So bladder also in a male, especially in a male, females you don't get that much because they don't have this prostate enlargement. But in males you get bladder outflow obstruction in old age frequently, and then you get enlarged bladder. Now, the clinical point about the peritoneal reflections and bladder enlargement is that since the peritoneum does not cover the bladder in front, it only covers the superior surface of the bladder. When the bladder gets filled, peritoneum gets lifted up with the bladder. So when the bladder lies here behind the anterior abdominal wall, there is no peritoneal covering in between the anterior abdominal wall and the bladder. Peritoneum lies above the bladder. So what you can do in the wards is that if you try to catheterize try to put a catheter. Now this is a female body, okay, but in a male, if you try to put a catheter into the urethra and you fail, several times you fail because it does not pass through the obstruction, then if you need to have an immediate relief to the pain of the patient because the bladder is full, before you can do anything else, what you can do is you can put a needle. You can insert a needle to just above the symphysis pubis. Okay, so you intake just above the symphysis pubis here through the anterior abdominal wall. The middle part of the anterior abdominal wall, you have the linea alba. You don't have blood vessels or nerves there. You just at the center above the symphysis pubis, you put a needle directly into the enlarged bladder, and you can you can remove urine from the bladder. When the bladder is emptied, it will go down and you can remove the needle. Now the nice thing here is that because the peritoneum does not lie in front of the bladder, you can directly enter the bladder without entering the peritoneal cavity, because the uh, issue of piercing the peritoneum and entering the peritoneal cavity is that you can introduce infections into the peritoneal cavity, and that can cause peritonitis. Okay, so infections and inflammation of the peritoneal cavity is called peritonitis, and it can be very it's serious. It can be life threatening because peritoneum can easily send these infections, bacteria, into the bloodstream. So within a day or two you will get septicemia, and you can die of it. Okay, so remember this point. Then about the pouches, we have already mentioned about the rectouterine pouch here in a female. I'm referring to rectouterine pouch, which is also called pouch of Douglas, and in front you get rectovesical pouch between the rectum and the bladder. Vesicle refers to bladder. Okay, rectouterine behind, rectovesical in front. In a male, since there is no uterus, you get sorry, I confused. Okay, uh, don't get confused. Okay, now here it's like this. In a female, you get uh, rectouterine, then uterovesical between the uterus and the bladder. In a male, since there is no uterus, you get rectovesical. Okay, rectovesical between the rectum and the bladder. You get rectovesical pouch. So that is this one. In a male, you get rectovesical pouch. In a female, you get rectouterine and uterovesical pouches. I have written it in the opposite direction. Okay, so in a female, you get rectouterine and uterovesical pouches. Okay, in a male, you get rectovesical pouch. So that is the confusion. Okay, I should have written it in that direction. Okay. So remember this point. Then the other important point, clinically important point here, from the middle third of the rectum, we said the peritoneum gets reflected first onto the posterior fornix of the vagina. Posterior fornix is here. Then the posterior surface of the uterus. Now, at this point, if someone wants, at this point, someone wants can enter a needle through the posterior fornix into the pouch of Douglas. Now, we know that there's a risk of entering a needle into the peritoneal cavity. This is the peritoneal cavity. But the clinical point here is in the erect posture. The lowest position, the lowest part of the peritoneal cavity in a female is the pouch of Douglas. That is the most dependent part in the erect posture. So if you have a tumor, a cancer in the abdominal contents, gut cancers or ovarian cancers, you can have deposits, cancer cell deposits in the pouch of Douglas. So if you detect some mass or something in the pouch of Douglas, if you want to do a biopsy and take a part of it, easiest access might be through the posterior fornix, unless you want to put a tube and some endoscopic surgery. You can enter through this one. I don't know details about this. You will learn it during your clinical years again. Okay. Then pelvic fascia. Sometimes people get confused about the terminology of pelvic fascia, different layers of pelvic fascia. Now, pelvic fascia has two components: parietal pelvic fascia and visceral pelvic fascia. Now, it is continuous with the abdominal and perineal fascia. You can study that later. Now, the parietal pelvic fascia, this one, it lines the pelvic walls. Now, these are the pelvic walls. It lines the pelvic walls and like this, it lines the pelvic walls, and it also lines the pelvic diaphragm or the pelvic floor. Okay, so when we say superior fascia of the pelvic diaphragm and inferior fascia of the pelvic diaphragm, they are also parietal pelvic fascia. Not only the fascia that covers the walls, even the fascia that covers the floor here, they are parietal pelvic fascia. And this parietal pelvic fascia is named according to the muscles. When they cover muscles, you give them names. Now, even here, you call it superior fascia of the pelvic diaphragm and inferior fascia of the pelvic diaphragm, these two. And here, now this, we have already said that the pelvic diaphragm is attached across the obturator internus fascia. Now, obturator internus fascia is also parietal pelvic fascia. And at the back, when the parietal pelvic fascia covers the piriformis muscle, before it enters the gluteal region, when the piriformis muscle is covered, when it forms the posterior wall of the pelvic cavity, that is called piriformis fascia. That is also parietal pelvic fascia. Okay, so all this is parietal pelvic fascia. So then what is visceral pelvic fascia? Now we have said that this blue line is the peritoneum. Peritoneum gets reflected over the pelvic organs the way we have described already. So you get parietal pelvic fascia here on the lateral wall and on the pelvic diaphragm, that is parietal pelvic fascia, and you get this blue line of peritoneum. These are pelvic organs which are subperitoneal. Now if you fill this gap between the peritoneum above and the parietal pelvic fascia below and lateral, the gap between these and the pelvic organs, this light green area is actually the visceral pelvic fascia. So the visceral pelvic fascia actually it fills the gaps between the pelvic organs, and it helps to bring neurovascular structures from the lateral pelvic wall into these pelvic organs. And And you can see in this diagram also, it's nicely put. You can see these green areas are actually visceral pelvic fascia. So they actually form septa between these organs. You name, various septa, and it forms not only septa, it forms very strong ligaments that attaches the pelvic organs to the lateral pelvic walls and stabilize these organs, especially the ligaments attached to the uterus. They are actually thickenings of the visceral pelvic fascia. Okay, thickens in certain places and form ligaments to support viscera. Okay, so that is about the general things about the pelvic cavity, pelvic fascia, pelvic diaphragm and all. We will, since there are not many lectures, we will go through some of the organs as well. It's 9:15. We can go through some of the organs as well. If you take the uterus, uh, uterus has two main regions. The lower part of the uterus, which is called cervix, forms the lower third of the uterus. Okay, lower third of the uterus, that is below this line. You can see the blinking line. So below that line is the lower one third, which is called the cervix of the uterus. Then the upper two thirds, that is that area, upper two thirds, that area is formed by the body of the uterus and the fundus of the uterus. Body and the fundus of the uterus. So that is a basic thing that you need to remember. And it is a thick-walled muscular organ with three layers contributing to form it. Outside you get the perimetrium, then you get the myometrium, and then you get the endometrium inside. Okay, so myometrium and endometrium inside. So these are the three layers. Okay, you know that the uterus lies between the bladder in front and the rectum behind, so that you have the pouch of Douglas or the uterine pouch behind and the uterovesical pouch in front in a female. And the position of the uterus varies with the distension of the bladder. When the bladder distends, the uterus is pushed upwards slightly. And the distension of the rectum also can change the position of the uterus slightly. Then if you consider the structures attached to different areas of the uterus, now there are three structures at least attached to this part of the uterus. So this part of the uterus, upper corners of the uterus are called conum of the uterus. Okay, so I think it's cannot write. Okay, conum of the uterus. It's called conum of the uterus, and to the conum of the uterus, three structures are attached. One is the fallopian tube or the uterine tube. This one. Okay. Then the other one is the ligament of the ovary or the ovarian ligament. Then there's a third one on the other side, anterior side, is the round ligament. Okay, is the round ligament. It is on the anterior side. So these three things are attached to the conum of the uterus. Then you get the vagina attached to the lower part of the uterus, the cervix of the uterus. This is the ureter. This is the ureter related to the lateral fornix of the vagina and the cervix of the uterus. We'll come back to it later. Okay. Now, this is how the ureter is related to the uterus. Now, this is the uterine tube, and this is the broad ligament, the two-folded peritoneum with the mesovarium, and this is mesosalpinx. Okay, mesovarium and mesosalpinx. We have discussed the extensions of the broad ligament. Now this is the lower end of the broad ligament. This is the lower end of the broad ligament. The ureter, if you remember, ureter starts from the renal pelvis and lies in the posterior abdominal wall, coming behind the peritoneum, retroperitoneally behind the peritoneum, through the posterior abdominal wall, enters the pelvic cavity after passing in front of the sacroiliac joints, and still lie at the back. And then here it is coming. Here is going to enter the bladder, which lies in front of the uterus. Bladder is somewhere here. So in the process, coming from the posterior side and trying to go to the front, it passes below the broad ligament. You can see it passes below the broad ligament, lateral to the cervix of the uterus and the upper part of the vagina. And the important point is at that point you can see here the uterine artery, which gives blood supply to the uterus. Uterine artery crosses the ureter at right angles to it. Okay, crosses the uterus crosses the ureter to enter the uterus. So uterine artery crosses the ureter lateral to the cervix of the uterus, or the posterior fornix, the lateral fornix of the vagina. We'll come back to the fornices later. Upper part of the vagina, it crosses the uterine artery. They cross each other. So there's a clinically important point here, because when you tie the uterine artery to remove the uterus surgically, you have to tie the artery and obstruct it to stop bleeding. So accidentally, the surgeon, the obstetrician or gynecologist, can, when he ties, if he's not careful, if he does not detect the ureter, identify it and put it aside, he will ligate the two structures together at this point. And when he cuts the artery before he removes the uterus, he will cut accidentally both together. He cut this and this both. So there will be obstruction to the ureter. Now this is fallopian tube. This is fallopian tube. You can see now this is anterior and this side is posterior. Immediately in front and below the uterine tube, you get the round ligament. So antero-inferior to the uterine tubes, antero-inferior to the uterine tubes, you get the round ligament. And the postero-inferior to the uterine tubes, you get the ligament of the ovary, or the ovarian ligament. Ovarian ligament. And you can see something else here. Now that you can see very clearly here, I'll show you. Now you get the ovary here and the uterine tube here related to the ovary here. And this is, we said this is ovarian ligament, or the ligament of the ovary. And there's another ligament here attached to the ovary. And this is the ligament that brings neurovascular structures and lymphatics to the ovary, not this one. This is just an attachment. So this is the ligament that brings blood vessels, which is ovarian arteries, veins, and nerves, and lymphatics to the ovary. This is called infundibulopelvic ligament, or you call it suspensory ligament of the ovary. The terms are written somewhere, you will see it. The position of the uterus, I promised you to discuss about the position of the uterus. In a normal person, the uterus is anteverted and anteflexed. Anteverted and anteflexed. Normally it is anteverted and anteflexed. Now anteversion is the forward tilt of the cervix of the uterus relative to the axis of the vagina. So that is this one. Okay. Forward tilt of the cervix of the uterus, that is that part, to the axis of the vagina. Okay, so this is this and this one. Okay, so that is called anteversion. Anteflexion is forward tilt of the body of the uterus relative to the axis of the cervix. So that is this one and this one. So that is that angle. Okay, so here you can see the definition of anteverted and anteflexion. So the normal uterus is in this position, so it is anteverted as well as anteflexed. Now in different people you can have different positions. If this is in the other direction like this, you can have anteversion and retroflexion, or you can have the total angle would be in that direction, so you can have retroversion and retroflexion. So based on the position, you can give the names based on these two angles. Okay. So if someone asks, what is the normal position of the uterus? You have to say anteverted and anteflexed. Then the blood supply of the pelvis and perineum. The blood supply of the pelvis and perineum is done by the internal iliac artery. So this internal iliac artery is an important artery. This is questioned in many places, even when it comes to the lower limb blood supply. If you remember, we have discussed about the cruciate and trochanteric anastomosis. Then we have said that if there is a proximal block in the femoral artery, blood supply to the femoral artery will come through the branches of the internal iliac artery through trochanteric and cruciate anastomosis. So that is one point. Then the second point was when it comes to the blood supply of the femoral head. Again, we talk about especially the trochanteric anastomosis. And again, internal iliac artery contributes to the trochanteric anastomosis and partly to the blood supply of the femoral head. And in small children, before puberty, before the epiphyseal plates of the femoral, the femur are closed, the internal iliac artery contributes to supply in children, supply the head of the femur through the obturator, through the branches of the obturator artery, which are branches of the internal iliac artery. So because of these points, it is important to remember the internal iliac artery. You already know that the femoral artery bifurcates at the lower border of the L4 vertebra in the posterior abdominal wall and gives rise to the common iliac arteries. And the common iliac arteries, which you can see here, common iliac artery divides into the external iliac artery and the internal iliac artery in front of the sacroiliac joints. And the external iliac artery runs along the pelvic brim and passes below the inguinal ligament here, passes through the femoral sheath below the inguinal ligament and enters the lower limb as the femoral artery. Internal iliac artery enters the pelvic cavity and gives its branches to the pelvic organs and the gluteal region later. Now, the first thing you need to remember is that it divides into an anterior division and a posterior division. A large anterior division, this is the large anterior division, and a relatively small posterior division. Then the anterior division, the posterior division, the small posterior division has three branches: iliolumbar, lateral sacral, and superior gluteal arteries. This is more important than the other two because you have seen the superior gluteal artery in the gluteal region. When you dissected the gluteal region, you have seen this emerging into the gluteal region over the piriformis muscle. Now, all these branches, they supply the lateral wall of the pelvis or the gluteal region. None of these branches coming from the posterior division out of the three will supply any of the visceral organs. Therefore, all these branches are called parietal branches. Okay, they are all parietal branches. Then from the anterior division, the large anterior division gives 9 branches usually. And these 9 branches can be easily remembered if you remember in sets of 3. There are 3 branches going to the bladder, which are called superior vesical and inferior vesical arteries and obliterated umbilical artery. Okay. And there are 3 branches going into other viscera. Now this is going into bladder. These are also visceral branches. And then the 3 branches going into other viscera are the middle rectal artery, uterine artery, and vaginal artery. Now later, maybe in the next slide, when we discuss about the blood supply of the uterus and vagina, remember that the uterine and vaginal arteries are branches of the anterior division of the internal iliac artery. And about the middle rectal artery, now for it to be middle rectal, you have to have a superior rectal and an inferior rectal artery. Now if you remember correctly, when you dissected the abdomen, you have seen the superior rectal artery, which is a branch from the inferior mesenteric artery. Okay, it gives all colic arteries, sigmoidal arteries, and then the last one is the superior rectal artery. Then the inferior rectal artery, it is a branch that comes from the internal pudendal. It's a perineal artery, comes through the perineal area. So that's another one. The middle rectal, is coming from the anterior division of the internal iliac artery. Then the three parietal branches, there are three parietal branches, just like in the posterior division, there are three parietal branches. One is the obturator artery, other one is the internal pudendal artery, and the last one is the inferior gluteal artery. So this is inferior gluteal. You have the superior gluteal coming from the posterior division and inferior gluteal coming from the anterior division that will go into the gluteal region and supply. Then the other important artery that you can see here is the internal pudendal artery. Now, internal pudendal artery is the artery of the perineal area, and that is the artery actually that gives rise to the inferior rectal artery and the perineal arteries. So there is a lot to read about the branches of the internal iliac artery, and you need to remember these branches in order, because clinicians also, when they come for viva, your vivas, they ask these branches, and in the postgraduate exams, if you happen to see a postgraduate exam or later when you do a postgraduate exam, if this area is questioned, they will expect you to remember these branches in that order. So you can see actually the anterior and posterior divisions here, and the 9 branches of the anterior division. I will not go into the details of that, and the 3 branches of the posterior division. Now you can see the uterine and vaginal arteries here. Okay, uterine and vaginal arteries. We'll come back to it. Okay, so here it is. Now, when it comes to the blood supply of the uterus and ovaries, first concentrate on the ovaries. You can see the ovarian arteries here, which are paired arteries arising from the abdominal aorta. Then they have a fairly long course behind the peritoneum, retroperitoneally. They enter the pelvic cavity, and from the lateral pelvic, they enter the lateral pelvic wall, and from the lateral pelvic wall, they pass through the suspensory ligament of the ovary, which I showed you before, which is also called infundibulopelvic ligament. And it comes through the suspensory ligament together with ovarian veins, lymphatics, and nerves, and supply the ovaries. So that's one point. Then you can also see, now this is the internal iliac artery. This is the anterior division of the internal iliac artery here. From the anterior division, as we mentioned in the previous slide, you get the uterine artery and the vaginal arteries. Now this is the uterine artery going to supply the uterus, and this is the vaginal artery coming to supply the vagina. There is a lot of anastomosis between these all these 3 arteries. We will try to discuss about this anastomosis here. Okay, so this is the point that I mentioned, infundibulopelvic ligament or the suspensory ligament of the ovary, which brings these blood vessels here. Okay, and you can see that the uterine artery here. Now this is the other point. You can see this is the ureter, and this is the uterine artery. You can see the ureter and uterine artery crossing just lateral to the cervix and the upper part of the vagina. And you can see, okay, if you don't hear, just let me know. It says the internet connection is unstable, it might go off. Okay, so you can see the uterine artery coming here and giving several branches here. We'll come back to these branches later. You can see that the uterine artery gives rise to branches. It gives rise to branches passing through the mesosalpinx and anastomosed with the branches from the ovarian artery. Okay, so the ovarian artery and vessels are here. There is an anastomosis between branches of the uterine artery and branches of the ovarian artery in the mesosalpinx area. You can see it here. And as a result, medial 2/3, up to this part, medial 2/3 of the uterine tube is supplied by the branches of the uterine artery. And the lateral 1/3 is supplied by the branches of the ovarian artery. Remember that point. And you can also see that the uterine artery, now this is the vaginal artery here, vaginal artery, the uterine artery branches anastomosed with branches of the vaginal artery here. Not only that, uterine arteries send branches in front of the uterus and behind the uterus on the other side, which are called arcuate arteries. So you have uterine artery here, you get anterior and posterior, the other side, arcuate arteries. They also anastomose with each other. The two uterine arteries anastomose through the arcuate arteries. And all these arteries will supply the uterus. So this is the point that I mentioned. I will not mention it again. Okay. Then these arcuate arteries, these arteries that pass in front and behind, arcuate arteries, okay, these are the arcuate arteries, okay, and they give deep branches that enter into the uterine wall. There are different names given for, you get this radial arteries and all that, but the important ones that you need to remember are the straight arteries and the spiral arteries. You can see the straight arteries and the spiral arteries. Spiral ones are more important because when you study about the uterine cycle, you learn about different layers of the endometrium. You have a stratum functionalis and a stratum basalis. During the menstrual cycle, this is the one that breaks down, stratum functionalis. Now, the reason why it breaks down is this, because the spiral arteries, these arteries are sensitive to hormonal changes. And withdrawal of progesterone towards the end of the endometrial cycle constricts these spiral arteries and precipitates an ischemic phase to the stratum functionalis, that is that area. Because of this ischemic phase, stratum functionalis breaks down and gives rise to menstruation. Okay, leaving the stratum basalis behind. So this part will not break down. So remember this point and relate it to this area. Then the nerve supply of the uterus, these are all just small points. There is autonomic supply from inferior hypogastric plexus. I will not discuss about superior and inferior hypogastric plexus, it's a little bit complex. But remember that inferior hypogastric plexus is the main autonomic plexus that supply the pelvic and perineal organs. And the sympathetic supply to the uterus is vasoconstrictor. So it constricts the blood vessels. And the other point that you need to remember is that the uterus can contract without nerves. So when the muscles are stretched, when you have oxytocin hormones and all, it can contract. So you can have labor in a paraplegic woman where the uterus contracts. Then the pain is carried through pelvic splanchnic nerves and sympathetic nerves. I think it's not a very main point. But when you say pelvic splanchnic, that is parasympathetic. Okay. So that's why I say it's complex. This pelvic splanchnic nerves and sympathetic nerves contribute to form this inferior hypogastric and superior hypogastric plexus. If you want to read, you read Richard Snell Clinical Anatomy. There's a very nice account of superior and inferior hypogastric plexus. Okay. And the cervix and the body of the uterus are relatively insensitive to cutting and burning, but the uterine tubes are very sensitive to cutting and burning. Uterine tubes are highly sensitive. Now this is a diagram of the ovary, just to show you all these different ligaments that we talked about. You can see this is the cortex of the ovary and this is the medulla of the ovary, that area. You can see the blood vessels, the ovarian vessels, they enter the medulla here. Follicles lie at the periphery, close to the cortex of the ovary. And you can see the two ligaments. This is the ovarian ligament that does not bring blood vessels, but it just attaches the ovary to the cornu of the uterus. But this is the ligament, the infundibular pelvic ligament or the suspensory ligament of the ovary that brings neurovascular structures and lymphatics into the ovary. That's what I wanted to show here. Then the vagina, which is a fibromuscular expandable tube directed upwards and backwards in the standing position or the erect posture. The anterior and posterior walls are in contact. So it's flattened antero-posteriorly like a sheet. The cervix projects into its anterior wall. So if the vagina is like this, cervix projects into its anterior wall like this. So the vagina completes like that. So the anterior wall is shorter compared to the posterior wall. So it's 7.5 centimeters to 9 centimeters. And because of this projection, you create a groove all around the cervix. So that groove is called the fornix. So you have the anterior part of the groove is called anterior fornix here. Then this is posterior fornix. Then you get lateral fornices on either side of the cervix. Okay. So the posterior fornix is the deepest one, where you get the pouch of Douglas in that area. Okay. Okay. So the anteriorly, the lower part of the vagina, the urethra is related anteriorly here, and to the middle part and the upper part, the bladder is related. Okay, so these are the relations of the vagina. Then posteriorly, you can see here, to the upper part of the posterior fornix, the pouch of Douglas is related here. Then you get this is called denon-bilious fascia or rectovaginal fascia. Now in males, this denon-bilious fascia is well developed, but in females, it's not well developed. Some people don't even like to call it. Therefore, but just remember, technically you need to know it. It's not well developed, but you get denon-bilious fascia here between the vagina and the rectum. So that is related to the middle part of the vagina posteriorly. Then inferiorly, you get a structure here called perineal body. We'll come back to it when we discuss the perineum. So perineal body is related to the vagina posteriorly. And laterally, you get the levator ani. Because the pelvic diaphragm is, you can see the pelvic diaphragm here. Oh no, it's not pelvic diaphragm, sorry. So you see the pelvic diaphragm here. So you get the vagina like this. Pelvic diaphragm is related like this. So that's why you call it a lateral relation. Okay, it's at a very high angle. And then you get the ureter related to the lateral fornices. We talked about the ureters getting related to the lateral fornices. In the blood supply of the vagina, now you get the vaginal arteries from either side, and then they unite and form a central artery, which is called the azygous artery. So you have an anterior and posterior azygous arteries going down. And as we said before, there's a lot of anastomosis between the uterine artery and the vaginal arteries. And other than the uterine artery, even the internal pudendal artery and the middle rectal arteries anastomose with the vaginal artery. You don't have to know all these details. Okay. Then the nerve supply of the vagina, this is clinically important. Nerve supply of the vagina, the posterior part of the vagina, we are referring to the lower part of the vagina here. Upper part of the vagina, you don't have somatic nerve supply, you only have autonomic nerve supply, visceral nerve supply to the upper part of the vagina. Lower part of the vagina, the posterior part of the vagina and the vulva are supplied by branches of the pudendal nerve. Whatever the name you give to these branches, they are all branches of the pudendal nerve. So that is that part. And the anterior part of the vulva, that area, and the mons pubis area is supplied by the ilioinguinal nerve. Now you have seen this ilioinguinal nerve when you dissected the posterior abdominal wall. It is a branch from the lumbar plexus of nerves, which comes through the inguinal ligament and comes out to the superficial ring of the inguinal ligament and supplies this area. Now the important point here is that during childbirth, to relieve pain, sometimes injection is given, an anesthetic injection, local anesthesia is given to the pudendal nerve, and pudendal nerve is blocked at the ischial spine. You know what is ischial spine? You can do a vaginal examination, touch the ischial spine with your index finger, and then you direct the injection to the pudendal nerve, which is related to the ischial spine posteriorly, and you can block the pudendal nerve so that you can relieve the person of pain, because this whole area, as I said before, is supplied by the branches of the pudendal nerve. But the issue is the anterior end, it is not supplied by the pudendal nerve, that is that area. Therefore, pain can still be there. So if you want to relieve the person, female, of total pain, you might not do it totally, but if you want to anesthetize the whole area, you have to give injections to that area, local anesthesia. Okay, blocking the pudendal nerve will not block pain to the anterior part of the lower part of the vagina and the vulva. Remember this point. Okay, so this is a clinically important point that can be checked in exams. Then the upper part, as I said, of the vagina is supplied through the inferior hypogastric plexus. I told you about this plexus, and it is only sensitive to stretch. Upper part, there is no, it's not pain sensitive, it's only visceral sensations. And blood vessels, smooth muscles, and glands are also supplied by the inferior hypogastric plexus. Then the ligaments of the pelvis, you will have, I think, separate lectures about the ligaments. But for the moment, remember the important ligaments are the round ligament, uh, sacrocervical ligament, transverse cervical ligament, which is also called cardinal ligament, and pubocervical ligament. All these will have cervical, because they are all attached to the cervix of the uterus. And these three ligaments, second one, third one, and fourth one, they are the important ligaments that maintain the position of the uterus, maintain the stability of the uterus, suspend the uterus. Round ligament is also important to keep the anteversion position of the uterus. But the broad ligament, even though we call it broad ligament, it is not important to uh, as a ligament to keep the uterus in position. Okay, it only brings blood vessels and all that. It's just double folded peritoneum. So these four ligaments are important for these reasons. Okay. So here you can see the cardinal ligament or the transverse cervical ligament here above the levator ani or the pelvic diaphragm here. You can see how it is related to the attached to the cervix of the uterus. So below this, below the pelvic diaphragm, you can see this area, which is called ischioanal fossa. We will discuss that later. So the pelvic cavity, this is the perineum area. Okay, this is the area of the perineum. Pelvic organs lie in that area above the pelvic diaphragm. Then few things about the urinary bladder. In young children, empty bladder can project above the pelvic inlet only in young children, but in adults, it lies below the pelvic inlet. But when the bladder is overfilled, as we said before, it can, even in adults, it can get raised above the pubic bones, which you can detect in the lower abdomen. Okay, we have discussed all these points, I think. So the ureters will enter the posterior wall of the bladder, and the urethra will leave the the floor of the bladder.